Welcome, everyone. I'm Dick Deming, Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And we are in October, and you probably know that means Breast Cancer Awareness Month. And who should we have? No better guest than Dr. Susan Beck, the head of the MercyOne Breast Cancer Center, the Breast Center, Katzmann Breast Center, at the Comfort Health Center for Women. Yes. Welcome, Sue.
Thank you. Yeah. Thank you, Dick. It's joy to be here. It really is. And thanks for inviting me.
Well, I've been looking forward to this with excitement, but also a little bit of sadness because Dr. Beck has shared with us that after a very long and illustrious career, she has decided that that she's going to be retiring.
Yes, that's true.
So the end of the year.
The end of the year.
Yeah.
Yeah.
Well, we're going to take that as an opportunity to talk about how breast cancer treatment has changed over the decades. So share with us a little bit about yourself. So where did you grow up?
Des Moines, Iowa.
Here in Des Moines, Iowa.
Yeah.
Okay. And where did you go to high school?
Roosevelt.
Okay, Roosevelt, Rough Rider.
Yeah.
What was your claim to fame in high school?
Well, I was a flautist.
Okay.
And I was a flag carrier.
Okay, in the marching band.
In the marching band.
So instead of playing the flute in the marching band, you were a flag carrier.
Yep.
Was that considered like more prestigious?
Yeah, we got to wear cowboy boots and
all
kinds of fun stuff. And I played the flute in the orchestra. Yeah, it was great.
Okay.
It was a great opportunity.
Oh, what was your favorite song to play on the flute in the orchestra?
Oh, gosh. That's a tough one. I'll think about that.
Okay.
I'll get back to you.
Okay. What else did you do in high school that distinguished?
I ran hurdles.
You were a hurdler?
Yes.
Oh, wow. Did you get to compete like in the Drake relays?
No.
How about state tournament? No, state track meet?
I was always kind of second,
Okay.
There's always one that was just a little bit faster. But when they were not running, I was first.
Okay.
So
And what did you do when you graduated from high school?
So, while I was in high school, I have to say I was kind of a workaholic, and I kind of let my track go because I wanted to work in the fabric store across the street from the high school.
So I know that you are. So I'm going to have to point out, I was commenting to Dr. Beck on how beautiful her blouse is, and then she shared with me that she made it herself. She knitted it herself.
Yeah,
her blouse.
Yeah.
So you had an interest in fabric and knitting, and I have to think that there's a relationship between knitting and sewing and becoming a surgeon.
Yeah, I think definitely. It's just a mindset also of finding something, identifying, and wanting to finish it and get it done, create something, make something better. So I worked, then my whole senior year in the fabric store. And then I went to Iowa State for college.
And when you started Iowa State, what was your first declared major?
Zoology.
Zoology. Okay.
I wanted to be a veterinarian.
Okay. And then when did that change to becoming a human animal doctor?
Well, my dad was a dentist, in town,
Okay.
Ronald Hufford, and 5th Street, West Des Moines for over 30 years. And after my first year, he said, animals just can't talk to you as good as people. So they can't tell you what's wrong all the time. So, then I started thinking, well, maybe I want to go in with my dad and be dentist. So I was accepted at the University of Iowa in dentistry, dental school. And during that time that I met my husband, he went to Iowa State too. And it just, I don't know, it just seemed like that wasn't going to be what I wanted to spend my whole life doing. I think the drill sound kind of put that on my, but they have fun stuff now. But anyway, so I had two uncles who graduated from Des Des Moines University, or it was COMS then,
Mhm.
College of Osteopathic Medicine, Health Science.
And were these your dad's brothers?
And they, one was a brother-in-law,
Okay.
and they worked in Colorado.
Okay.
And so I knew them and went out and visited how they did things, and decided that I think I'd like to apply to the medical school in Des Moines. And so I did, and was accepted, and got married.
So you got married, went to medical school. So then in medical school, were you one of the students that you liked everything? I remember every rotation I did, it's like, oh, I'm going to be that. I'm going to be that. And how about you? Were you liked everything, or you knew early on that you really wanted to be a surgeon?
Well, it was a funny story. Actually, in medical school, I was a PA or a TA, teacher assistant in pathology.
Oh, okay.
Looking at slides. I liked the pathology
Okay.
part. And then, of course, that morphed into, the labs, the animal labs. We were able to have animal labs there.
And since you were a zoology major for at least a short time, you probably doing the
Iowa State had a
fetal pig dissections.
All of that.
Yeah, you loved that. Okay,
pretty much.
So we're talking about this retrospective. So let me ask you. So right now, most people, I don't know if they know, but over 50% of every medical school class are women.
Yeah.
When you were in medical school, what percent of students were women?
So that dovetails with the last question you had. And so there was about 15 in a 300 class at COMS. And
so about 7%.
Right. And the urologist came up to give us a lecture, and he looks around and he goes, I've never seen so many women in the class. And he goes, I bet they won't want to rotate with me, because you're a urologist. That was my first year. And so you know what I did.
You signed up for urology for your first rotation.
Yeah. I didn't know what it was I was getting into. But anyway, they did a lot of open kidney renal things at that time. And so I think that was really the beginning of my love for surgery. I stood a lot of time above the ether screen watching and listening and seeing how things went in the OR, and didn't have a lot of support from the nursing staff. I was probably always in the way. But anyway, I learned a lot. That's kind of how it started.
So then when you finished medical school, it's time to apply for residency, and you decided to apply for general surgery.
Yeah. And that was at Des Moines General. And they have really the longest running general surgical residency program in the state, or at least in Des Moines area. It's over 100 years now old. And they'd never accepted a female before. No. There'd been some, gynecologic surgeons, but not in the general surgery program. So, I was fortunate enough. They decided to give me a chance.
Wow. You're the first woman in the surgery program.
In that program. Mm-hmm.
Wow. So how was that in terms of, the work ethic, the hours, but then also being the only woman in that?
Yeah.
Did you have to feel like you had to be extra good in order to?
Well, I just felt that I always really worked hard on excellence. And being an intern there, of course, it was first internship year and then residency. So I knew most of the people, and they knew me, and they knew how I worked. So I didn't have really too much trouble. And some of it isn't worth talking about, but you just kind of keep your eye on the carrot at the end, and you just work through, whatever.
Work hard, focus on quality.
Yeah.
Model the right behavior.
Any adversary, you just let it go. Yeah. And it was fine.
Wow.
And then, of course, I joined my trainer when I was done. And about the same time you came to.
Yeah. So when did you finish your residency?
89.
In 89. Yep. And I came to Des Moines in 89.
Yeah.
Yep. I had finished my residency a few years before I was at the National Cancer Institute, but we both started as staff
Right.
at Mercy the same year, 1989. Yeah.
Yeah.
And so you joined that group. You're, again, the only woman surgeon in that group. So back in when you came out of training in 89, there really was no such thing as a breast surgeon.
No.
General surgeons kind of did everything.
Yes.
There were probably some surgical specialties at that point. Maybe surgical oncology existed as a fellowship. Maybe thoracic surgery existed. Cardiovascular.
Yeah.
But breast surgery as a fellowship did not exist.
No, really not until later. Until a group of general surgeons got together to form the American Society of Breast Surgeons, and they met like 2 years before they really opened it up as a group that you could join. All the general surgeons can join, and let me tell you, the majority of the American the ASBS, American Society of Breast Surgeons, were general surgeons, because there was not a fellowship at that time. But the desire was to really, across the country, make the surgical care and the care for breast cancer and breast diseases more homogeneous across the United States, because, you might be, in Des Moines and you might be able to get a lumpectomy, but you might be in Montana and they don't really have that, then you're just going to get a mastectomy.
So it was to standardize care.
Absolutely.
To promulgate the best practices, the newer practices, and come up with standardization of care. So obviously when you started, you were doing everything.
Yes.
So besides breast work, which we'll discuss in more detail, what other aspects of general surgery did you really enjoy?
So that's a good question. I mean, it was an exciting time for me to be a general surgeon, because that was the beginning of laparoscopic surgery.
And maybe describe what it was like before laparoscopic, and what did laparoscopic surgery bring into the surgical arena.
So it really was utilized in gallbladder surgery initially. And so when I was a resident, just a dweeb, I was on the end of the retractor so the surgeon could see an open incision.
Yeah. So before laparoscopic, big incisions, open up. Yes. Get your hands in there, do the surgery, and then you got to close everything up.
Yes.
And lots of recovery time after you do a great big surgery. And then maybe to compare, what would the incision be like for laparoscopic, and how would you do that?
So, the incision for an open could be, almost 10 inches in the middle, or an angled coker. Over time, that got smaller, but for laparoscopic, it was just 4 little incisions, one in the belly button for the camera, and 2 to 3 others just underneath the rib on the right side, to be able to use the instruments to remove the gallbladder.
So the camera is allowing you to see what the instruments, where they are, and you're operating the instruments by hand. So it's kind of like long pinchers that you operate from outside the body, but the pinching and the clipping and the cutting happens inside the body. Right.
Which, could be ergonomically challenging, for the surgeon. And of course now, they've morphed to robotic, which makes it much more comfortable for the surgeon. But
and for those who don't know, then talk about the next generation. You go from laparoscopic to robotic. Right. And what does robotic mean? You just train R2D2 to do the surgery for you?
Yeah, actually, the surgeon sits like you're sitting separate away from the patient, and the patient is docked on the bed where the arms of the robot hold the instruments and the camera. And everything's digitalized, so the visual is quite nice. The only problem is you didn't have a lot of tactile feedback. They're getting better at that.
So you're not really at the bed. You're off to the side. The instruments are going into the body, but you're operating the instrument from the other side of the room. Yeah. And you have a video screen, so you see what's going on inside. And realistically, the patient could be halfway around the world.
Exactly.
And you could be doing the surgery.
Yes.
Yeah.
And
Robotically.
that happened.
Yeah. Yeah.
It did.
So that's how much training does it take to learn? Because obviously, if you're in a residency program now, as part of your residency, you learn how to do that. But if you've already been out of training and you're in a busy practice and now you've got to learn a brand new technique, what's that like?
It's funny because when we were doing just laparoscopic, which morphed from gallbladder to appendix to colon to then bariatric, which I participated in.
Yeah, and bariatric surgery, for those who don't know, is surgery for weight loss purposes. So it's like banding the stomach, making the stomach smaller, or
rerouting the small bowel. And we'd wear a 3D headset on. That's where we had our three-dimensional headset, but we'd still be using
made by
arms.
Atari, or
yeah, Apple glasses. I don't know. No, but it was more cumbersome. It's much nicer now, but there's advantages, to the robotic and being able to be closer to the patient. If there's a problem or a bleed or something happens, you're right there. You can take care of it.
Mm-hmm. So sometimes you do have to open them up.
You have to open, even robotically, yeah.
Mm-hmm.
So to learn all that, in the beginning when we were going through that, there were oftentimes we would be having vendors bring all their equipment and models to work on in the back of, a semi-truck parked it in Chicago Airport hotel. We'd go and we would learn and we'd get those training there.
And you'd go for a weekend training in Chicago and practice on
torsos or
animals.
Mostly
or
cadaver.
Mostly models.
Yeah.
Cadavers. Okay.
Frozen. And then that morphed then to, Cleveland, Cincinnati has a really nice Ethicon. And then it kind of morphed into a nicer, more controlled lab setting. It was more fun to go there instead of the other. And same with robotic. And now we have simulation labs. Mm-hmm. And that's how we're teaching residents and other surgeons that are wanting to learn in a simulation lab.
Mm-hmm. And then when did you decide that you wanted to specialize in breast surgery? How far into your career? And how's that process like? Well, I just want to do breast. And then I imagine that not all of your partners were universally accepting of you doing just breast.
They were fine.
Okay.
As long as I took call.
Okay.
No, but, I was taught to do everything from tonsillar abscess all the way down. But as a female surgeon, also attracted the female population.
Patients who wanted to.
And as you know, I did a lot of gynecologic surgeries laparoscopically, laparoscopic assisted hysterectomies and things like that. Did a lot of those things. But there was a point when I was really intrigued by this American Society of Breast Surgeons, and I went to LA for their first meeting. And it was so impressive that what I learned there, I could bring back to my practice and use it right away. Mm-hmm. And I think that was really the beginning, and the research that came with that. In 2000, we opened our Katzmann Breast Care. And one of my excellent trainers, Dr. Kendall Reed, and then we had support physicians, both medical oncology and you yourself in radiation, helping us develop this multidisciplinary approach to breast care. And that's really, I think, the really beginning. And you've seen the multidisciplinary approach for other cancers. But I think really breast was one of the first to really bring that and really reduce a lot of the variation and suffering that women and some men, 1% of men with breast cancer, have to go through.
Right. To standardize the care and to bring, by multidisciplinary, it is obviously the surgeon, but the medical oncologist the radiation oncologist, the plastic surgeon, the pathologist, the radiologist, all on a team. So it
Yes.
used to be that cancer conferences were like show the weird and unusual cases. And really what a multidisciplinary is that every case gets presented and everyone's case is talked about, and that it's not like somebody's off on their own doing whatever they want. It's
Right.
like every case gets presented and what is the standard of care for this patient. And
Yes.
we hold each other accountable for
Yes.
practicing high quality and offering patients the best standard of care.
Absolutely. And it helps because there might be something you're not necessarily thinking about, but then when we get the group together, we can see, hey, this could be an option. And like we had talked earlier on previous conferences, is that when we review our overall survival over the years, we have seen an improvement in overall survival in breast over the years, over the last 2 decades. So just this multidisciplinary approach has made that happen.
So over the course of your career, and again, you got out of training. Training was, 4 years of college, 4 years of medical school, 5 years of residency. So by the time you're in your first year of training, you're already a young adult approaching middle age. And now you've had a career that has spanned 36 years. What would you say have been some of the major changes, and you've already highlighted some of them, but the major changes in breast care that you've seen over the last 36 years?
It's better.
So more standardized,
It's
more
more
people
standardized.
understanding what the guidelines are and adhering to them.
Yes.
Okay.
And of course, the whole surgical aspect has changed. It's not just a radical mastectomy where you have an up and down incision and muscle taken and skin grafts and big arms and lymphedema. And what do we do with that? No, it's just, it started with the modified radical after the radical and found that it wasn't inferior.
Mm-hmm. So again, you said it started with radical mastectomies back in the days of Halstead.
Yes.
Then the next minimalization of the surgery was a modified radical. And what was the modification?
The modification is we did not take the muscle underneath there, and it was more of a transverse incision, not up and down, didn't take a lot of skin generally. We still took a fair number of lymph nodes, though.
It's a lot of lymph nodes. So the entire breast, but not the muscle,
Right.
but still a lot of lymph nodes from under the arm.
Right.
So you were left without a breast, and also a fairly high risk of having lymphedema or swelling of the arm.
Yeah.
So then from modified radical mastectomy, what was the next surgical progression?
Right. The next then started actually in Milan, where lumpectomy was considered. So actually just removing the lump, also sampling some lymph nodes, and then the addition of radiation therapy following the lumpectomy. And they found that that was not inferior to a bigger surgery such as mastectomy. Better cosmesis, better quality of life for the patient as well. Still had some issues, we still could have some lymphedema. We could still, require to have chemotherapy. That component I didn't comment on, but the surgical aspect of it found that we were safe in reducing the amount of surgery. So a de-escalation of that.
Same cure rate as the bigger surgery,
yes,
but much better cosmetic results and also fewer complications in terms of
yes,
lymphedema and other.
because of the addition of radiation therapy, which we didn't have. And of course, you can comment on how that's morphed over
Yes.
the years.
Yes. So
Improved.
a lot of the treatment from radiation and surgery kind of are parallel. It's like instead of surgery removing a lot, it's removing less. And with radiation, instead of treating great big fields, it's let's treat smaller fields, try to incorporate less normal tissue, be more focused on the treatment, and also more recently to reduce the number of treatments by being more targeted, a higher dose per day, but fewer treatments.
Yes. And of course, the movement now is reducing the surgery for certain tumors at a certain age, over 70, 15 millimeters in size, favorable markers, actually just an office procedure with cryotherapy and freezing the tumor.
Right. So we may actually eliminate surgery
In certain
in
cases.
certain
Yeah.
early stage breast cancers.
Yeah.
So
Exciting.
the obvious, or the ultimate of minimal surgery, no surgery.
Yes.
Yeah.
Yeah.
There's also been an emphasis on, as we talk about reduction, paying attention to the side effects. So kind of the American way, and I'm going to editorialize a bit. The American way is always like more is better. And, but we know that some of what we do doesn't actually improve the overall cure rate.
Right.
It reduces the risk of a local recurrence, but it doesn't really change the cure rate, but it can add more in terms of side effects.
Yes.
So always keeping that in mind, we're now looking at where can we, when appropriate, eliminate the radiation as part of it.
Yes.
When can we, if appropriate, not do the chemotherapy? When
Yes.
can we, avoid the anti-estrogen? So there actually are clinical trials now that look at, and as you mentioned, they're called non-inferiority. We're not trying to show that eliminating some of these treatments gives you better results. We're trying to show that it gives you the same results in terms of curing the cancer, but better outcomes in terms of side effects.
Exactly. And as you mentioned earlier, some of the surgeries have changed because we have better ways of telling if someone is a candidate for preventative surgery.
Mm-hmm.
Having plastic surgeons help us with that.
And talk about what do you mean by preventative surgery?
So some of you have heard that there are mutations that put a woman's lifetime risk of as high as 80% for developing a breast cancer, BRCA1 and BRCA2 mutations. And so sometimes that is determined by family history. Sometimes it's determined by testing after they've already developed a cancer. But if we can find those mutations and surveillance, and also help women decide, when they would like to do preventative surgery, we have them talk with a plastic surgeon, and oftentimes if a decision for preventative surgery such as a mastectomy, bilateral mastectomy,
so removing the woman's
the breast
so that she doesn't develop breast cancer,
right, is something that has been really beneficial to many women, and we can do this now in a way that is aesthetically pleasing as well. And we found that we didn't have to always just take the nipple, because there's a lot of breast tissue underneath the nipple, but the way we do the surgery now, we can reduce that to just about 1 to 4% and still be safe and still have the breast look like a breast.
So you're talking about this procedure called bilateral nipple-sparing mastectomy, where you make an incision, remove the breast tissue, but you leave the skin and the nipple.
Exactly.
And then eventually implants, either silicone implants or tissue, can be put up into the cavity, so that after you're done, you've removed both the breasts, but it looks like the woman still has all the skin, the nipples, and then filler to present an appearance that the breasts are still there.
Yes. And certainly emotionally and psychologically and quality of life, it's made a big difference for many women. The procedure can even be done, if they've had a cancer, you can sometimes do that nipple sparing or skin sparing mastectomy, so that they have more of just the natural form. And it still can be done if someone requires radiation therapy, and still can have a fairly very good result good disease control as well.
So sometimes that preventative therapy surgery is actually done in conjunction with surgery for breast cancer. So they might have
Yes.
breast cancer in one breast, but you do the bilateral and remove the breast tissue on the other side as well as a preventative.
It's a decision many young women choose, for many reasons. And again, a positive genetic mutation or at risk or family history. Under the age of 40, many women will choose to have that so that they are not revisiting that in the future, because even though recurrence or having a second primary is not all that common, but the younger you are with the first cancer, it is higher. It gets up to about
Really?
8% as far as having a second primary, compared to if you only had 4 or 5 years of life expectancy, the recurrence rate is only about 2%.
And then let's talk a little bit about the changes that have occurred with our medical oncology colleagues, because whereas when you and I started practice, it was always surgery first, and then once the pathologist looks at the final pathology, you decide, do you add in chemotherapy? Do you add in radiation? And now, based on the biopsy and our ability to look at the particular markers of the cancer,
Yes.
we may determine that let's reverse the order and actually do the chemotherapy up front.
Yes, and that's just been a real advantage to treatment for breast cancer. So breast cancer can have personalities to it, and different markers. Markers we mean by, does estrogen seem to make it grow? Does estrogen, or one called human epidermal receptor protein 2? And if we know that up front, and other things such as size of the tumor, sometimes we'll hold the surgery and we'll have the chemotherapy first. And we can monitor the response with imaging, such as an MRI. And then when it's time to go into surgery, after the completion of the chemotherapy, if we find that there's no living cancer cells in there, that has the best prognosis. They have the best disease-free survival.
And we see that
cure.
not infrequently,
That's correct.
where by the time you do the surgery, there's no cancer left.
Correct.
And now we're looking at trials where, okay, maybe in those situations we can back off radiation or other additional forms of treatment if we find that the cancer is all gone by the time you do the surgery.
Yes. And some other innovations to de-escalate the surgery. So there's a condition called ductal carcinoma in situ. It is when the cancer is in the duct, but it's not invading, it's not invasive. And so it's an easier one to cure, but when it's multiple areas of the breast, sometimes we have to do a mastectomy for that. Well, the standard of care is we would have to sample some lymph nodes under the arm. And anytime we're in there, surgery or radiation, either it can affect the lymphatic drainage and sometimes cause some swelling. So there became a movement of trying to reduce going in and sampling a lymph node at the time, or reduce that risk at the time of the mastectomy. In other words, normally we would map with a special dye, a radioactive dye, the lymph nodes through the breast lymphatics, which when the breast is intact, that works really well. But if you do a mastectomy, you can't map very well because you've disrupted those. So we have a way of using a magnetic dye that we can inject into the breast that will stay in the lymph nodes for about a year. So when we do the mastectomy for precancers or ductal carcinoma in situ, we can wait for the pathologist to tell us if there's invasive disease or not. And a lot of times there's not invasive disease. So we've saved not taking lymph nodes by using this special, it's called MagTrace, special dye. And if there is positive invasive, then we can always go back and just remove that lymph node. So we've really helped reduce that really life-changing side effect called lymphedema on those kind of patients.
Mhm.
We know that the lymphatic drainage from the breast and the arm is shared by some lymph nodes about 30% of the time. Most of them are up above high, but about 30% can share from breast and arm. So that's why when we take a lymph node or several out, you can have swelling of that arm because they share that drainage pathway and you've disrupted it in surgery. So if we can save that, that's a big advantage.
So we've talked about how breast cancer care has changed during your career. You've touched on a little bit. What are some of the things that excite you about clinical trials that are being done that look to what breast cancer surgery might be in the future? And you already touched on it with the cryotherapy.
Right.
Maybe talk a little bit more about that. And in addition to cryo, are there other techniques that are being looked at, like radiofrequency ablation or focused ultrasound, as ways of actually killing the cancer without doing surgery?
Right. To go back in history just a little bit, Mel Silverstein, San Diego, was really the father of what we call oncoplastic surgery. And he decided at that time that, how can I get this tumor out and still have the breast look like a breast? And so he brought his plastic surgeon in and he developed this oncoplastic. And so there are many women that have very, very large breasts and a really small tumor. And to do a mastectomy and even radiation, sometimes there can be side effects. So Dr. Silverstein decided let's have the breast reduced in size at the same time as we take the tumor out. And that was so exciting. I mean, and
do the other side as well.
And then do the other side for symmetry.
For symmetry, to make them both the same.
And so that was really exciting when all of that came about. And again, we learned how to do that and those special incisions and everything like that. And then, as a breast surgeon, I'm ultrasound certified from American College of Radiology. And so we could use a small device with ultrasound assistance to go in and actually remove small fibroadenomas and tumors at one time. We tried with a radiofrequency. It was directed by ultrasound. You could see the mass, and then you numb the skin, and then as that would advance and you get to the position, the basket would come out and go all the way around the mass, and then you could pull that out that way without going to the operating room. The only problem is electrical radiofrequency. It's heat, so it's not as comfortable as cold, like cryotherapy. And they could not really prove margins real well. So after we did that for a while, we decided, to abandon that.
Okay.
The cryo is cold, and so it's numbing, but it can form an ice ball and form a mass that lasts for several months too. So it is work going through some process of what's the best. What we used to work together on too is with lumpectomy and radiation. Remember the partial breast irradiation with the special catheters, a mammocyte.
Mm-hmm. Right. That was a technique that we used for a while. And now there are other radiation techniques where at the time of lumpectomy, you can, in the operating room, do radiation just to that lumpectomy cavity and then not have to do the radiation afterwards. So that's a technique that's being used now in some centers to give the radiation at the time of lumpectomy.
Yes, yes.
Do you ever think we'll get to the point that we'll just find the right medicine that kills the cancer cells and, eliminate your job and my job in terms of surgery and radiation?
The tagged virus or the tagged, you already do that with prostate, right?
There are different techniques that are looking at, immunotherapy and developing cancer vaccines.
Yes.
So let's get a little bit philosophical. You're ending a 36-year career as a surgeon here at Mercy. What are you most proud of in terms of your career?
Oh, I've always had the privilege to participate in other surgeons' education
Mm-hmm.
and surgical residency program from the very beginning to when I was chief resident until
Right. So
now.
you went from being resident, chief resident, to being staff and teacher for the residents.
Yes.
Over the course of your career, what would you guess would be the number of patients you operated on in your career and the number of surgeons you trained in your career?
There's a lot of cases. And I'm reminded of that sometimes because when I first was out in practice, we would go to rural hospitals to help out to do the laparoscopic, but also I was on call for C-section. And so when they come in office and they say, yeah, I remember you did my son's C-section, he's standing there and he's,
He's 45 years old.
so,
but what would you get? How many surgeries do you do a year?
Oh gosh, my first year, it was a lot. When I went through my certification, I had 2,000. Yeah.
2,000 a year.
In the first
times
years.
36.
Not so much now.
Times
I'm
36 years. Wow.
Anywhere.
But even 1,000 a year.
We're talking small.
36,000 people you've operated on.
Yeah.
And then how many residents a year?
Started out with 4, 1 per year, 4 at a time, and of course now it's 4 per year.
Yeah, so clearly
it's really
trained hundreds of surgeons. So
and some of them still work around here and still I get to talk to.
Your legacy is obviously the legacy of creating the breast cancer program, the National Accreditation Program for Breast Cancer, the Katzmann Breast Center, but your legacy is also the thousands of women that you have treated that appreciate what you did to help cure them of their cancer, and the hundreds of surgeons that you have trained in your lifetime. Yeah. The world is better because of you, Dr. Beck. The world is much better because of you.
We would hope in some increment, yes.
Well, let's open up to questions. So we got a live studio audience. You get first dibs at asking Dr. Beck questions. If you're watching us live streaming right now, please put your question in the comments section of the software you're using to watch us, and we'll get to your questions as well.
I just wanted to, start off with a couple of comments that we have online. Becky is watching on Facebook this evening. She says, "Beautiful Dr. Beck. She saved my life with a bilateral nipple-saving mastectomy. She is so wonderful, and I'll forever thank God I got her." And she says, "2 of the best hearts and doctors in this video. How lucky we are."
Thank you.
Well, thank
you, Becky.
Yeah,
thank you.
I agree with Becky. Here we go. Ron has a question.
That nipple saving surgery with mastectomy, how recent of a development is that?
How long have we been doing that?
Yeah.
Well, I would have to say at least a decade.
Oh, yeah.
Mm-hmm. Yeah. When we first started, and different variations, the incision changed over time, and it had to do with our quality of equipment and lighting. Also was very important because you can imagine we're kind of working from underneath. But first we started out with a incision around the areola.
Around the nipple.
The nipple color, not the nipple itself, but the color. And then we found out that we had too much stress and the incision would break down. And so then we had a lateral extension to that. So it was kind of right up front in your face, this scar. And then we found out that when you had the right equipment and the right electrocautery to help clot or stop the bleeding as we're doing surgery, we could make the incision underneath the breast. So, the woman won't see the incision underneath. And then that morphed to just a little curve over to where we could do the breast and we could do the lymph node mapping and sampling through one incision instead of having multiple. So it is morphed over that period of time. Yeah.
I can remember the first time I saw a patient who had bilateral nipple sparing mastectomies and reconstruction. And so I'm going in, okay, this patient's had bilateral mastectomies, and I go to examine the patient. It's like, wait, this patient still has breasts. This could not have had a bilateral mastectomy. So I still remember that very first patient walking in thinking she had bilateral mastectomies, and my examination was contrary to what the record said.
Well, you're not the first, because I have a patient who's a missionary in Colombia, and we did bilateral nipple sparing, and they keep wanting to do mammograms on her. And so,
Kevin, you have a question?
Yes. Surgeons over time have developed a particular reputation. He's a surgeon, mostly, and men developed that reputation. Have women surgeons done anything to alter that or make it a little softer? Or?
Well, I think we see there's been some studies on women surgeons. The number of women in surgical residencies now is approaching almost 50%. When I was first in practice, and they said, you're going to see Dr. Beck, and I walk in the room, and the man would go like, and I'm seeing him
this
for
must
a
be
hernia.
Dr. Beck's nurse.
Yeah. and they have a hernia, so they're kind of anxious, or they have a hemorrhoid, But I always would just calm them, and I would just say, it's okay. My hands are nice and small. So I'm not going to hurt you as much. And, that seemed to be the trick. And I was able to really navigate that better than I thought. Surprisingly, I would walk into a room, a woman, say, who was in her 70s. And we're talking back in 80, 91, 92. They didn't want anything to do with me. They wanted a male surgeon. So, it could happen either way. It was just what they were used to. They wanted the male doctor. They didn't want the female doctor. So, it was kind of both ways. But I think that, actually, now, as there are more female physicians and more female surgeons, and now with the new robotic and the minimally invasive, I think that the public's pretty equal on accepting whoever comes in now. I don't think the stereotypes have really kind of faded. I really do.
Annie is also watching on Facebook tonight. Annie asks the question, is there a blood test for BC in the works? And if so, could you please tell a little bit about it?
So I think that's BRCA.
Well, I think she might be
that.
breast cancer. Is there a blood test for breast cancer?
Okay.
So,
yes.
So as you already talked about, the BRCA is a genetic. You do a blood test or saliva to see what genes you got. But we do now have blood tests that can detect circulating tumor DNA in the bloodstream. So
They call that a liquid biopsy, but yeah, right now we're using that mainly to check for recurrences, surveillance after treatment to see. But there will be more information on that over the years. I think we'll have more and more information. I think the most anxiety producing part of it, of doing it when you don't have cancer, is you may have something in the blood that says you could have a cancer, but we can't find it on any scan.
Mm-hmm. And I would say that one of the areas of research is a blood test that is a multi-cancer early detection blood test. So one of the products out there is called Gallery by Grail, and it can detect up to 50 different types of cancer on a blood test. And this is as a screening It still hasn't been proven to be like as effective as a mammogram in detecting breast cancer. And it probably is going to detect more aggressive cancers. So a very slow growing, indolent, non-aggressive breast cancer is less likely to be picked up on a blood test like that. But it's a great question because clearly doing blood tests to actually detect cancer is a reality. And with more research, that will become part of screening for cancer. Gary, did you have a question?
Yeah, I was interested in the, you were a musician as you were growing up. And do you see that those that can play an instrument, very well, can make better surgeons than those that have not had any particular practice? Or has the day of robotics kind of masked that out?
No, I think you have to still have some of those skills robotically. You may not be at the table, but you're working like you are doing a video game. And
So the dexterity.
Dexterity is still very, very important. So yeah, and I think just the creativity part that music brings, the mathematical part that music brings, I think all of that helps really make a good surgeon, and many other professions I might add as well. But the dexterity is still important throughout the whole surgical practice, even though robotics is in now, but it's not an end all. And not everything can be done robotically. So just to quickly say, it's going to be a while before we do a robotic mastectomy because it's just really not feasible at this time unless the robot arms get much smaller. There's still a need for the tactile feeling of an abnormal tissue, which you can't necessarily with a robot.
So Dr. Beck, what does the next chapter of your life look like?
Grandma.
So more grandma time.
Yeah. I'm going to investigate that question. I can't answer it 100%. I mean, I have so many hobbies, and I have a retired husband now from January.
Right.
But I'm just going to need some time to figure that out.
Mm-hmm.
It's been so long, and I love what I do, and I'll miss people. And so I don't know how that's going to look 3-6 months from now, but I'll find out.
Okay. Well, again, I want to thank you for what you have done for me, for all of our patients, for the program that you have created, for the legacy that you're leaving, for the number of individuals that you have touched. And thank you so much. And I know that whatever your next chapter is, you will bring joy to those that you interact with. So
Thank you.
Thank you so
You
much.
as well. Thank you.
If you know someone that would benefit by watching this program, you're in luck because this program has been recorded and will be available on demand for you or anyone to watch on the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. I hope you'll join us again next week.
Thank you.
Thank you.